Good evening, you're all very welcome. It's 6:10, so I'm going to call that 6 o'clock Irish time. For all of you who are here in the room, you're all very welcome. Apologies for the delay in the start. We have nearly 250 people registered for this evening's event, so we were holding off to ensure as many people were here as possible. Also, a very big welcome to anyone who is online watching us this evening. So we introduced this last year, whereby obviously we have all of you here in front of us, but we also have an opportunity where people at home in their living rooms can listen in and watch this evening's presentations. And I know last year we had people from all over the world, as far-flung as Egypt and Australia, so we're very much welcoming to everybody who has taken the time to come here this evening. My name is Eva Havrdrova and I'm Chief Executive of the Multiple Sclerosis Society of Ireland. So MS Ireland is the only national organisation providing information, support and advocacy services to people with MS. And obviously there are lots of literature available outside this evening, and there are many members of the MS team here. But if there's any information from this evening, obviously all of that will be available to people on the website after this evening's event. I would like to start by saying a very big thank you to Novartis and the team, because without the support of Novartis, this evening's event would not take place. So we're very grateful for that, and we do hope you enjoy what is laid on for you this evening. We also know, I suppose, how important it is, how important research is, and it's with the fact that tonight is MS Research Explained, is a very important event in the MS calendar. There are a number of things that we have introduced this year. So we've started an MS Research e-zine. So the first one came out in June and again is available to you on MS Ireland's website. And the next one will be developed in December. And we're also putting together a 3-year strategy for MS Ireland in relation to research. We had a very generous donor this year who gave funds towards a project in Galway, which is looking at research in relation to mindfulness and MS. So again, a range in the research that we're involved with. Many of you will know the research that we carry out with the University of Limerick around physio and getting the balance right. So again, lots of I suppose the psychosocial side of the research is very, very important to us. In 2015 as well, we awarded the Dean Medal, which is a medal that we award every 2 years, and we're very delighted to have one of the winners here speaking to you later on this afternoon. And I would like to thank and take the opportunity to thank the 826 people with MS who participated in the My MS, My Needs research that was disseminated earlier on this year on the MS Ireland website. So again, what we were trying to do is get a feel for, I suppose, the temperature of where MS is at in Ireland specifically in 2016. And we have some research survey flyers outside for people if anyone is interested, or if any of you have taken part in that. So also I'd like to say, if anyone would like to tweet this evening, the hashtag is #ThinkMS. So if any of you would like to participate in that, please do. I know Wilka, one of our bloggers, is here and will be actively tweeting on our behalf. So all that's left for me to say is again thanks to Novartis for supporting this evening's event. Also to say, please, we hope that you enjoy it, and I'd like to introduce you to our first of 3 speakers. So the format will be, we will ask the speaker to come to the stage. Nonnie is going to speak for 15 to 20 minutes. She'll take 1 or 2 questions at the end of that, and then we'll move on to the second speaker. So Nonnie McNicholas is in her 2nd year working as an MS Research Fellow in St Vincent's University Hospital. Her medical doctorate will focus on cognitive changes in multiple sclerosis, and she is currently involved in a number of research topics related to this. She began as a specialist registrar in neurology in Cork University Hospital in 2013, and she did 1 further clinical year in Beaumont Hospital before commencing her research in St Vincent's in 2015. And I should say that Nonnie was the successful winner of the 2016 Dean Medal. So I'd like to introduce you to Nonnie McNicholas.
Thanks a million, Eva. So I'm going to talk tonight about cognitive dysfunction in MS, and talk about a bit of the research that we're doing in Vincent's around it as well. So cognitive dysfunction in MS is a relatively recent topic of interest in research in MS, so only really in recent years, but it's been a known feature associated with MS for much longer than that. And it was actually originally described by this neurologist here, Charcot, a French neurologist, and he described it over 100 years ago. And it's probably become more of a topic of interest since the advent of disease-modifying therapies and better physical outcomes. So people are focusing on other quality of life factors, and cognitive function is really the main quality of life factor apart from physical disability there. It's very common, and it's present in between 40 and 70% of people with MS, and that number varies in studies depending on the population of MS patients that are studied. And it depends as well on the neuropsychological tests that are used. It's very much under-recognised in MS, and particularly in early MS. And that's mainly because it's probably not tested for, because we don't have the people, the personnel, or the time in outpatient clinics to perform all the cognitive tests. So that's something that we're working on in Vincent's, to make cognitive testing applicable in a clinical setting. It's very disabling as well, and it actually leads to more withdrawal from work and from social activities than does physical disability. So cognitive dysfunction can actually present with change in mood and with excessive fatigue, and also can present with withdrawal from social activities and from work. The main domain that's initially affected is impaired information processing speed. So what we mean by that is the speed at which we process verbal information and visual information around us. So keeping up in conversations with lots of people and focusing and concentrating on things. So other domains that are then affected quite a lot are attention and concentration, verbal and visual memory, and executive functions, which in MS is in particular verbal fluency and word list generation. So the aspects of cognitive impairment that are of interest and are studied in research are its mechanisms, so how cognitive impairment develops in MS, its assessment, so the neuropsychological tests that we do to test for it, its relationship to disease activity, so how it's related to relapse frequency and physical disability, and things that protect us from developing it, and then if it's developed, what things are possible to treat it. So I'll touch on all these aspects. So for the mechanisms, we all know about MRIs and about demyelinating lesions, and these lesions can lead to relapses and can lead to developing physical disability, but actually there's conflicting evidence for their presence and the development of cognitive impairment. And some people can withstand lots and lots of demyelinating lesions and not develop cognitive impairment, and some people can't withstand as much. So they're probably not the only feature that are responsible for its development. So really, there's lots of different MRI sequences now in research that are being looked into it, but the one that's most strongly associated with cognitive changes is atrophy of grey matter. So demyelination is inflammatory lesions in the white matter tracks, and the grey matter appears to also have a role in MS, and probably a much bigger role in cognitive impairment. So monitoring of this atrophy by percentage brain volume change with your annual MRI scan will probably come into play in future years, and we're doing this in our research in cognitive impairment in Vincent's Hospital at the moment. So this is just an example of brain volume changes over time. So you can see in the scan on the right, there's more cerebrospinal fluid here. So this ventricle here is bigger 3 years later, and this cerebellum here at the back, you can see that it's slightly smaller, and there's more cerebrospinal fluid around it. So that's evidence of grey matter atrophy and percentage brain volume change over time, and that's associated with cognitive impairment in that person. So for its assessment, we use neuropsychological studies, and the two main studies that have been well established in testing for cognitive impairment in MS are the brief repeatable battery of neuropsychological tests, and another one called MAC-FIMS, which is the minimal assessment of cognitive function in MS. And these are very good, and they're very sensitive and very specific for identifying cognitive dysfunction, but they require trained neuropsychologists to perform. They require bringing in special materials like tape players and different kinds of things. And the brief repeatable battery takes an hour to do, and MAC-FIMS takes 90 minutes. So it's not something that's possible in an outpatient clinical setting. So in order to address this, another test was made by a panel of neurologists and neuropsychologists. This is called BICAMS, the Brief International Cognitive Assessment in MS. And it's been validated as a screening tool for cognitive impairment in MS, and it doesn't need a trained neuropsychologist to perform it, so any healthcare professional in the MS clinic can perform it. It takes about 15 minutes to perform, and you don't need any specialist material, so it's something that could, if it's well validated, be used in a clinical setting. And it's been validated as a screening tool in 10 countries to date, including at Vincent's Hospital, and its role in monitoring cognitive impairment over time is something that we're trying to validate for it now as well, which needs further work. So this is the test of information processing speed that I was talking about earlier. So it's a test of visual information processing speed. So the participant is asked to look at this key at the top, and there are 9 symbols that match up to 9 numbers. It's called the symbol digit modality test. And the participants asked to call out the number that's on the key above when they read through the symbols. They'd be saying 1, 5, 2, 1, 3. And I'm very quick at that because it's all I do all day. So don't think anything if you can't do it that quickly. So we time everybody for 90 seconds and see how far they get, and then give them a score. And this is a test of verbal memory. So we call out a list of 16 different words to patients, and we call them out at the same speed, between 18 and 20 seconds each time we call them. And after each time we call them, we ask the patient to try and call back all 16 words if they can. And that's usually not possible in anyone, but people get better and better as they go along, and then we give them a score out of 80. And then we also test visuospatial memory. So we show patients different shapes and symbols, and we show them for 10 seconds, and then we take them away and we ask for them to be drawn back. And I think this test is really difficult, and it's impossible to draw them back, and they have to be drawn very, very neatly and very symmetrically. And I think men in general do better in this. I don't know if because they're better at visuospatial things. So this was the study that was done by an MS fellow before me, Karen O'Connell, and she validated BICAMS as a tool in an Irish population. And she did this by doing the test in 67 patients and 66 healthy controls. And when comparing the raw scores of each of the tests, there was a significant difference between them. So it was good at differentiating patients from controls, so it was probably a valid screening tool. And just when these were converted to scores based on standard deviations, where people could be classified as cognitively impaired or cognitively preserved, it could differentiate patients in control in the first 2 tests I showed you, the SDMT and the verbal memory test, but not in the visual spatial memory test. So more work needed to be done there. And since that study was done, I've followed on with a continuation study. So I wanted to look at BICAMS as a dynamic marker of cognition over time. So once cognitive impairment is identified, how good is BICAMS at monitoring it? And so we managed to get 38 of the 67 patients and 33 of the 66 controls, and we're still looking for the rest of people. So if anyone's in the audience, you can get in touch with me. So everyone was well matched between patients and controls in age and years of education, and in the time between the 2 tests. And with the follow-up testing 2 years after Karen's initial validation study, we can see that the test was good at differentiating patients for controls in all 3 cognitive domains that were tested. But there was no change over time in either the healthy control patients or healthy control population or the MS patient population. And we felt this is probably because most of the patients we had, were on disease-modifying treatments with relapsing remitting MS. So it was a relatively short follow-up period over 2 years. So there was no change in cognition. And when we converted this into whether they were impaired or not impaired, we could actually differentiate in all 3 domains this time in the follow-up testing. So the results show that BICAMS had an ongoing ability to differentiate MS patients from controls, but we need more work into using it as a monitoring tool over time. And our lack of change over time is probably due to a short follow-up period, relatively small numbers on the trial, and most patients were on a disease-modifying treatment, which is probably protective for cognitive impairment. So just touching on some other things, so relationship to disease activity, there's not a very clear-cut relationship to disease activity. So, you know, they say here at the beginning that, you know, when MS is in the more inflammatory stage, that things that might be affected are information processing speed, and that's usually what's affected initially, and things like concentration. And then maybe later on, executive functions, the verbal fluency and learning and memory can become affected. But really, the relationship to disease activity is not quite that clear cut. And in any study that we do, you'll always see a high prevalence of cognitive impairment, but you'll always see a third to a half of patients that are cognitively preserved. And it's, you know, there's a lot of interest in what protects people from cognitive impairment, and you know, some people can withstand a lot of disease burden and not be affected cognitively. And the thought that education and pre-morbid education is very protective, and being involved in cognitively stimulating activities and your occupation can be very protective to the development of cognitive impairment, regardless of disease activity. So Einstein would have done that. So with treatment, so once cognitive impairment is established, it's not been shown that it's amenable to any medical treatment. But really, the effects of disease-modifying treatments is probably beneficial, but randomized control trials have traditionally focused on, you know, annualized relapse rates and change in physical disability. But that's changing now, and so we'll probably see the benefits of DMTs soon. Then there's the question of whether statins, so cholesterol medication, is beneficial for cognitive impairment. And there was a study done in London that showed that statins had a really good effect on that brain atrophy that I showed you, that percentage brain volume change over time. But then when that study was continued on and neuropsychological tests were done in people, there were still beneficial effects, but less striking. So the role of statins isn't well known either. Cognitive rehabilitation can be very beneficial once cognitive impairment is established, and that's really going through very in-depth neuropsychological tests and being aware of, you know, what deficits that somebody might have and how to manage around them, and then cognitive retraining to try and improve areas that may be affected, and that's been shown to be very helpful and beneficial. There's been a lot of trials on different drugs for cognitive impairment, and they've all been unsuccessful. So I'm sure a lot of people have heard about Vampira, which can improve walking speed in some people, and it was thought that it might also improve cognition, but there was no significant difference in those who took it. Then other stimulant medications and the drugs that are used in Alzheimer's as well were tested, but they weren't beneficial, and that's not unsurprising because it's a completely different process. So there's a lot of work to be done really in all four areas, but just to conclude up, cognitive dysfunction in MS is very common. It's quite disabling and can, you know, lead to you know, more quality of life problems than physical disability itself sometimes, and it's very much under-recognised, so it's something everybody needs to be much more aware of, you know, the healthcare professionals and patients. So MRI, there's, you know, a lot of work done, but a lot more to do, and it gives us insights into the mechanisms of cognitive impairment. And we need to start assessing for it in clinics, but there's a lot of constraints with time and personnel, so this could be addressed by BICAMS, but we need to assess its role in monitoring cognition over time further. And there are very limited treatments, so more research is needed in that as well. So thanks a million, and I'll take one or two questions if anybody has one. Yeah, we're good.
I'm just wondering whether you've looked at the role of kind of fatigue on cognitive impairment, and whether this is kind of a temporary thing or permanent. And then when you're doing your BICAMS,
Yeah, so the question was whether fatigue influenced cognition, and I think, you know, everybody would know that having MS or not, when you're fatigued, you're not as quick at, you know, processing things, and you don't feel as kind of on the ball, so to say. But in a lot of trials, we always would do scales for anxiety, for mood, and for fatigue as well, to control those things. But in most studies, when fatigue itself, if you control for depression, fatigue doesn't seem to be a factor, but I'm not sure. There's a lot of interest now as well, and that's something we're going to hopefully try work on, and whether fatigue is related to increased sleep problems in people with MS, so, you know, sleep disorders, and whether they might actually be the link with cognitive impairment. So that's something we're going to be looking into, yeah, and we'll be doing BICAMS and sleep studies on people.
And the other thing, just the third part of BICAMS is dependent on somebody's manual dexterity.
No. Oh, sorry, yeah, the brief visuospatial memory, it is, yeah. Yeah. So, yeah, it's limited if somebody were to have a high EDSS score, so if somebody was to have a high level of physical disability, it would be limited. And the patients that we did the test in were generally quite well. Yeah.
Do you know if BICAMS have been validated for other illnesses, and can we hope, if this is the case, that it'd be better rolled out throughout the country to, I suppose, to make it more cost efficient, if you will?
So if BICAMS has been validated in other indices, what do you mean?
Yeah, if it actually takes care of more illnesses, maybe it's easier to roll it out to healthcare professionals where we know we're constrained by money and time.
Yeah.
Or is there a similar test that can be conducted with MS and other illnesses that healthcare?
Yeah, as in a kind of general memory test, like we always use. There's other memory tests that are used in Alzheimer's that are generally very available. I mean, this test could be, you know, if you have the time for it, if you can assign an extra 15 minutes to people in clinic, it could easily be rolled out. It doesn't require much, you know, financial investment whatsoever. I mean, you just need a few pieces of paper and a pencil and a rubber for drawing.
So what's stopping us now to roll that out throughout the country and to make sure it's more widely available to
its role in monitoring cognition, and, you know, even though we validated it, the drawing test actually wasn't validated the first time. It seems to be working the second time, but we need more numbers. So there's more research is needed at first, but I do think it's something that's going to be coming in. And if there's time constraints on even having the extra 15 minutes, the original one, the SDMT, that looks at information processing speed, which is the most important thing to identify first, I think that's something very easy to bring in and be done in 5 minutes in a clinic, which we definitely would have time for, yeah.
So more research.
Yeah. Okay. Yeah, just one more, yeah.
How do you differentiate between, it's like kind of a little bit like a fatigue question, how do you differentiate between, say, menopause and MS? Because I find when it comes with MS is, I never know what's my MS, you know, something else.
Yeah. As in causing fatigue?
Well, I just find my cognitive.
Yeah, that other factors can play in. And so the question was, how do we differentiate for other factors playing into cognitive changes, you know, and whether to know it's your MS or not. And I suppose in the research, the way we do that is by testing in controls as well, because there'll always be controls who fit into cognitive impairment, and there'll always be controls having a bad day, and, you know, the age range would account for all these different things and hormonal things. And that's the idea of trying to, you know, have have people who also might be tired that day or have other things affecting them, and seeing whether there still is a difference in the MS population. Okay, I hope that answers it. I'm going to have to leave, I'm sorry, but thanks. Sorry, thanks, Eva.
Thank you, Nonnie. Apologies, Nonnie has another commitment, so she has to leave, so that's why we put her on first. So just to put you under pressure, can anyone remember any of the list from list A? Any of the words that were on list A on Nonnie's slide earlier on? Pardon? Motorcycle, okay, anyone else? That's the only one I can remember is spinach and onions, and I think it's because I'm hungry. But anyway, that's neither here nor there. But no, I didn't want to put you under pressure, but I did think it's interesting. I was looking at it myself, and I was there kind of going, okay, if you genuinely said to everybody in the room now, could you take out a piece of paper in front of you and draw that, I think we'd all be fairly challenged. So, but it was really interesting, and we're delighted to have Nonnie here with us this evening. I would now like to introduce you to our second speaker for this evening, which we're absolutely delighted to have here with us. Eva Havrdrova is Professor of Neurology at the First Faculty of Medicine, General Faculty Hospital, Charles University in Prague in the Czech Republic. She obtained her medical degree at Charles University in 1981, went on to specialise in neurology and became professor in 2010. She is currently director of the Centre for Demyelination Diseases at Charles University and has published no more than 80 publications, including one obviously on MS, neuroimmunology, handbook of MS for GPs, and a number of publications for people with MS. I could actually go on for another 10 minutes with all of your relevant qualifications, but we are absolutely thrilled to have Eva here with us, and I'd like to invite her to the stage.
Good evening. I'm very happy to be here in Ireland, as I feel a special connection with this country. I will show you in a minute. I decided for MS 35 years ago, and I'm happy that I did it because now I see the progress in treatment. It's not the case in all the fields of neurology, unfortunately, but in MS we have seen enormous knowledge of pathogenesis and also treatments, and that's great, because in other diseases in neurology you see just progress in understanding what is happening but not able to help people. And so I'm happy that this is my specialization for 35 years now, and I will show you, these are my disclosures, sure, always. I will spend a minute speaking about MS in Czech Republic, because you may know the other name for the country, which is Bohemia, and the Bohemia is the Celtic word, and there were Celts living 500 years before Christ in our country, and there is a lot of Celtic blood in our descendants, and maybe this is one of the reasons why we have such a high prevalence of multiple sclerosis as well. And this is the link to countries like this, and Scotland, and all these regions. You see that we have 10 million population and around 17,000 of patients with multiple sclerosis, and I'm the head of the center where we follow up 4,000 of these MS patients, trying to provide complex care for them. Not only just medical care like prescribing drugs and doing all these tests, including BICAMS. It's validated for Czech Republic, for Czech language as well. And we have shown that BICAMS correlates not only with those big batteries, which are scary, because if you have to be tested for 2 hours, it's something which is not very pleasant, but it correlates very well with the ability to be employed. So unemployment increases if BICAMS goes down in scoring. So it's a really very important test. We have more than 2,000 of patients on disease-modifying drugs, and I'm happy that I was able to fight for the reimbursement of these drugs in our country, though this is not what I would like to see, and so I have some years to do it again and again. It's a constant fight with government and all these authorities. We try to have physiotherapists, psychologists, psychotherapists, social workers in my center, so people can be really advised how to cope with the disease, what to do with their social situation, and so on. We have also NMO in our country, but the prevalence is very low, and we see around 45 patients in my center. This is just the picture from Atlas of MS, and you see that the prevalence, which is here expressed in colors, is the same here and in our country. We are here, and you see that we are in the high prevalence area. Just to say something about the background, because I would like to move slowly to the topic, how this no evidence of disease activity concept developed, MS is now recognized as an autoimmune disease mostly. Of course, it has its neurodegenerative part, which is responsible for disability. But we know now that there are immune cells which everybody has in its body, but now they were somehow allowed to start an attack against the CNS molecules, mostly myelin sheath. And myelin is here for the nerve to conduct quickly the information through the CNS to the organs. And unfortunately, the inflammation caused by these immune cells destroys myelin and axons as well. And axons are responsible for the function. So if you are losing axons, you are losing the function slowly and, of course, sometimes invisibly, but it leads to the atrophy of the brain. And I will show you some pictures. We are doing a lot of research on that. Of course, there are many risk factors, not only genetics. Genetics is responsible for about 30% of the disease, because if you have monozygotic twins and one was diagnosed with MS, the other one has the probability to get MS only 30%. So 70% of the disease are environmental factors. And I hope in future we will be able to influence this. And there is, for example, a big study in New Zealand feeding small children with vitamin D, much higher levels of vitamin D than we get here or in my country from the sun, to see if the next generation will have less prevalence, lower prevalence of or incidence of multiple sclerosis. Of course, smoking is another factor, and again, you can do prevention. And there are many of these risk factors where you may do some prevention, especially in families where MS occurs, like less salt, not obesity, and so on. So we hope that there will be not only drugs to treat MS when it is diagnosed, but there will be some booklets to prevent it, you know, to give you to prevent it in your families, in your children, and so on. So I hope this is a great development. And of course, anti-inflammatory therapy is extremely important because it's the only thing which can preserve CNS tissue up to now. We do not have neuroregenerative drugs. We do not have anything which can force CNS to grow new axons, which sometimes are of 1 meter. We do not have anything like that. But if we stop destroying them, of course, they will be there and they will function. Unfortunately, it's not the case in all patients, and here you see the development of multiple sclerosis on MRI during 7 years. And here you see very small ventricles where the cerebrospinal fluid is created. And after 7 years, you see how big these ventricles are. It means that the CNS tissue was lost and the ventricles are environed. And you also see that there are some spots, some white spots, but here you have many lesions already confluenced. And this is also not good prognostic factor. And now we know that not these white spots, but the atrophy of the brain correlates with disability, and therefore the research in atrophy is now really growing, and we are trying to standardize our MRI measurements to be able to measure the development of CNS atrophy, because we know that if we are administering a drug and the patient is having no relapses, he's feeling well, but the brain is shrinking, the drug is not working well. And I think in future we will have some methods on MRI to see in 1 year, you do not have the right drug. You need some more effective drug because you are still losing your brain. We have created, therefore, a group of MS patients right from the beginning of their disease and healthy controls to be able to compare. And you see how the development of the brain atrophy looks like in healthy controls. Everybody loses its brain. Therefore, we are born with more cells than we need. But the rate of atrophy in normal controls is, in adulthood, is about 1 to 1.3% per year. In MS patients, it exceeds 0.4 or 0.5%. And some patients lose more than 1% per year. So the speed is 5 times higher. And of course, if you lose so much brain, the function must be impaired. And therefore, we really invest a lot of money to this research. As I said, there are some risk factors we can prevent, and of course, some risk factors we cannot. Genetics is something you cannot prevent. EB infection, which is present all over the world, you can hardly prevent, though there are some trials of vaccines against EBV because it's responsible for many other diseases as well, and some tumors as well. But the vitamin insufficiency, which correlates, of course, with latitude, you can prevent by feeding already children and pregnant women with enough vitamin D. Vitamin D was recognized mostly years ago, mostly connected with rachitis, and that's not rickets. That's not what we need. The vitamin has a lot of roles in immune system, and these amounts of vitamin D the immune system needs are much higher than you need to prevent rickets. And therefore there is a lot of research now, and it has been shown that even if you add vitamin D to interferon beta, which was the first biologicals used in treatment of MS, you get better results. So vitamin D can help a lot, and especially it may prevent multiple sclerosis because you see much less multiple sclerosis in the south of this hemisphere. Then smoking. Definitely smoking leads to more MS. 2/3 of patients are smokers or children living in smoking families. Smoking leads, if you are diagnosed with MS, smoke and you do not stop smoking, smoking leads to more atrophy of the brain, more lesions, more active disease, and more progression of disability. So I think it's enough not to smoke. Then salt. Salt is a pro-inflammatory factor. And if you give more salt into the culture of the cells you are studying, they are producing more pro-inflammatory factors. And obesity, especially in young ladies, maybe at the age of 15 to 18, is connected again with more incidence of multiple sclerosis. And then there is a huge new field which started with the discovery that our microbes in the gut are not just 5 or 10 types. There are a huge amount of types of these microbes, and they are living with us for thousands of years, of course, and they are helping our immune system to react properly to various agents which would kill us. So they are taking care of us, and they are helping our immune system to be working properly. But it was shown that in multiple sclerosis, the microbes are a little bit impaired. They are different. They let the gut leak, and some proteins from the food may go into the blood and cause some immune reactions. So there is a lot of hope that using the proper microbes may also help in multiple sclerosis. So in future, this will also be a huge field. I'm so happy that I am living in the time where we changed completely the treatment paradigm in multiple sclerosis, because when injectables were introduced in 1995 in Europe, or 1996 in my country, and 1993 in the United States, we were hoping that we would be able to decrease the number of acute relapses. That was it. Nothing else was proven for interferon beta. And we expected that if you had 3 relapses, you would have maybe 2 or 1 per year. And so it was expected that it is not completely stopping the activity of the disease. And few believed that there is any impact on disease progression, because the clinical trials which lead to registration of the drug and lead the drug to the market are only 2 years long. And it's a very short time in the period of multiple sclerosis, which is with you the whole life. And also the patients who were enrolled in the trials were said that they are in the remitting phase of the disease, but some of them had high disability. And if you have high disability, you can hardly believe that in 2 years with some suboptimal drug, some optimally working drug, you can reach some effect on progression of disability. So definitely, we couldn't expect anything from these trials. On the other hand, some people of these trials were found 20 years later, and it was shown that if they were not on placebo but on active drug right from the beginning of the trial, they are doing better after 20 years. So definitely there was an impact. And the impact was shown then in the real life data in databases which follow the patients up more than 2 years. So if you have a database and you have the follow-up of patients treated with these low efficacy drugs for 10 years, you see that there is a difference in comparison with the natural course of the natural history of MS. So in 1993, interferon beta was introduced, which reduced the relapse rate by only 30%, but 30% means versus placebo, and placebo is also 30%, even in European or Western population. It may be more in some other populations. So it's 50 to 60% of effect, but it's not too much, but we were happy to have anything. In some studies, it was proven that there is some minimal effect on disability. But unfortunately, there was no effect on brain atrophy development. On the other hand, these agents were tested in clinical trials right from the beginning, from the first attack, which is called clinically isolated syndrome. And all these trials showed that it's really important to start immediately when you are diagnosed, because if you start 10 years later, it may be too late. The other drug was glatiramer acetate. It's the second injectable, and it was introduced in 1996, and it was proven in head-to-head trials that the efficacy is the same. So this is the first published data from real world. This is the Italian registry showing that it was not a randomized study, not placebo-controlled study, but when the patient came into the office of the doctor decided, after the discussion with the patient, you start treatment with biologicals because I think as a doctor that your disease may develop not very benign, and the other patient may have said, I do not want any injections, I have injection phobia, and I do not want to be treated because I feel quite well in between relapses. But after several years, you see the difference. There was a difference in disability. So this was not minimal difference. It was several years of delay of disability difference. And so it was clear then from the CIS studies that if you treat late, you have no effect. If you start during remitting phase, you may have some effect, but of course, much effect you can get when you start early, because early means that it's not the start of the disease. We diagnose the patient and they have several lesions on MRI. So, and sometimes they say, okay, for 2 years I'm so tired, I'm not feeling well, and the disease is there already. So we do not start when the disease starts. So we always have a delay, but at least to start when clinically we diagnose the disease. And it was again proven in a real-world registry, which is the biggest database coming from many countries, but the center of the database is in Australia, in Melbourne. And again, those people who were not treated, they didn't initiate the treatment because, for example, optic neuritis, everything is okay after several weeks, and the young lady doesn't want to have injection spots, of course, because in these times, there were no tablets, there were only injections. And some of them decided not to start. All those who started on any injectable which was available did better after several years. So this is a proof that with the inflammation you have to do something right in the beginning. And then more effective treatments came. So we stopped to be satisfied with suboptimal response. we stopped to be satisfied with just decreasing number of relapses, because natalizumab, it was like a quantum leap. You know, suddenly, not 30% against placebo, but 68%, 70% against placebo. It was something which was not expected when the trial started. And the same is true for Alemtuzumab and acrelizumab. These are the most effective drugs today. And then, of course, the first tablets came, fortunately. It was fingolimod, and the effect of fingolimod is somewhere in between natalizumab and interferons. Dimethyl fumarate, which is a little bit less effective in trials than fingolimod. Teriflunomide, which is substitute for all these injections in those patients who do not want to be pregnant, because there is a procedure, you have to clean the body from teriflunomide if you want to be pregnant. But in comparison with injectables, teriflunomide showed the influence on the development of brain atrophy and disability, which correlates. So it's reasonable. And then cladribine is now, these two drugs are in the registration process, so we do not have them, but we hope to have them in 1 or 2 years. Cladribine is a cytostatics, which you just swallow several times per year, and then the rest of the year is free from treatment, like with Alemtuzumab, but these are, of course, injections. And it also has the possibility to postpone the disability and brain atrophy. So we have much more effective drugs. Of course, if you have something which is much more effective in Western medicine, it's always connected with some side effects, and therefore still the injectables are there because they are very safe. We know their side effects after 20 years of using them. And there are patients who are stable on them for many, many years. But these potent drugs enabled us to dream about something which has never been dreamed about. It was stabilization or even improvement in multiple sclerosis. The analysis of natalizumab trial, it ended 2006 or 2005. We counted relapses, we counted disability progression and MRI activity, and wanted a patient to be free of all these signs of activity of the disease. And we called it that time free, we called it that time free from disease activity. And later Gavin Giovannoni from London gave it the name no evidence of disease activity, so-called NEDA. So everybody in the MS field is now speaking about NEDA because you can compare trials. You see how many % of patients were able to reach NEDA with that drug. Of course, in each individual, the drug works differently. But the more patients are NEDA in that trial, it means that it's a more potent, more effective drug. So if the patient fulfills all the criteria, like without relapses, without disability progression, and without MRI activity, we call this patient NEDA. We use the term NEDA 3 now because these are 3 factors. And after the publication, you see it's already several years, we dreamed about something more. We have seen these patients having still more atrophy than healthy controls. And we were afraid that that will translate into more disability in the future. Because of course you invisibly lose your brain, and when you reach some threshold, it translates into disability. So we dreamed about a new possibility to add the atrophy. You can ask why to achieve NEDA. Of course, the patient without measurable disease activity. We can, of course, measure many factors. We can measure cognition, we can use better measures for walking, we can measure working capacity, and hundreds of things. But measurable disease activity is something which is feasible. It is something similar what oncologists use for patients who are treated for a tumor and they feel they have no activity of that tumor, they are not, or some may be cured, And this is so-called long-term remission. In rheumatology, rheumatoid arthritis, they use also biologicals, and they also use this term long-term remission. So we wanted something like that. You can compare across trials, as I said, and also you can, based on this, express what is suboptimal response. If you have relapses, it's suboptimal response. If you have disease progression, it's suboptimal response. If you have any MRI activity, though the patient is feeling well, you can expect something in the future. So it's suboptimal response. And there will be new European guidelines for treatment of MS issued, I think, in January. And they will express this possibility to use these measures to say this response to treatment is not optimal, we have to switch to more potent drugs. And this is NIDA4. We add here atrophy within a range of healthy controls. It's our dream. It's not feasible to reach today because the measurement of atrophy is not easy. If you measure the volume of the brain, which is wrapped all around, and you want to see 0.1 or 0.5% of change per year, you really need a very good technical instruments to do it and to standardize it. So it's not feasible in many countries or centers yet. It needs also cooperation with radiologists, and it's not easy to reach. So, but I'm a visionary, and I hope that this will, in several years, it will be all over the world possible to measure it. And you can ask if we can reach this NIDA concept with old-fashioned injectables, because it was not fantasized at all about it before 20 years when the trials with injectables were done. But now the injectables are used as a comparator in clinical trials with more potent drugs. And you see that you can reach it. These are two Alemtuzumab trials, CAREMS-1 and CAREMS-2. The difference is that here, these were patients treatment naive, so it was their first treatment. And you see that over 2 years, a quarter of patients were able to reach NIDA concept on injectables, of course more on Alemtuzumab. But these were patients with minimal disability and very early in the disease, within 5 years in the disease. The other ones were already patients pre-treated with something. So they had another injectable, different type of injectable, and they entered this trial within 10 years of their disease. And you see that immediately we cannot reach 1/4 of patients to be able to reach NIDA concept. It's less. And of course, each year when patients develop some activity, you lose this number, you lose this percentage. So it's a tricky concept. With low-dose interferon beta, we have these patients in my center, all followed right from the first clinical attack, treated with interferon within 4 months, and all of them having a lot of MRIs. And you can see that in the first year, the disability is not the issue, of course, in the first years of the disease for most patients. But to reach NIDA 3 after 4 years, it's like 10% of patients. So they all should be already switched to more effective treatments. And NIDA 4, it means including atrophy development, it's even less. Alemtuzumab, which I showed you the graphs for efficacy for NIDA, has also the ability to slow down the brain volume loss. And that's nice because though we do not understand how it does it, maybe it's really very anti-inflammatory, but also it switches the populations of white cells responsible for the disease to more regulatory ones, to more kind ones, which are able to help repair of the brain. So this is really a very potent drug. Of course, it's connected with some side effects, and you have to know how to handle this. But definitely we have in our hands already an instrument how to help patients with ongoing disease activity on other drugs. These are numbers for fingolimod, which was the first tablet put to on the market. And you see that, again, placebo patients are much less probably reaching NIDA concept. in comparison with treated patients. So you see that it's over 30%. In natalizumab trial, it was 37%. Here it's 32%. And it's true both for treatment-naive patients and previously treated patients. But of course, for treatment-naive patients, it's easier to reach this concept. And fingolimod was surprising when the trial was finished. We have seen that also this drug is able to slow down the rate of atrophy, and that's great. We also do not know how it does it. Maybe there are some, this is sphingosine 1-phosphate modulator, and these receptors are also in the brain. So maybe there may be direct action in the brain, but nobody knows how it is in humans now. But why I'm showing these two graphs is that if you have a lot of inflammation like here, these people had a lot of inflammation. They had gadolinium-enhancing lesions in the beginning of the trial at baseline. And these patients didn't have that much inflammation in the time when the trial started. And for these patients who had a lot of inflammation, the statistical significance of slowing the atrophy is present only after 2 years. So it means it takes some time to decrease the inflammation and to revert the degenerative processes into regenerative processes. While in these patients with a little bit less inflammation, it is statistically significant already in 6 months. Nobody expected anything like that. So it was a big surprise, and we are very happy that this drug is on the market. And with these more potent drugs, something new again appeared. Improvement of existing disability. Of course, we do not say that patients who are bedridden are able to walk, but you have some intermediate type of disability, so bed walking and all these other things, and you can improve it. And these potent drugs may improve it. And this is, again, some hope that in future we will have even more potent drugs making the improvement more possible. This is, again, data for Alemtuzumab. Alemtuzumab treated patients were 2.5 to 3 times more likely to have disability improvement within 2 years. So this is something my teacher, who died in 1999 and who was really very educated in immunology, would never expect anything like that. This is for natalizumab, again, one of the most potent drugs. Again, you see improvement. It's not just from the clinical trial. There is a big registry of natalizumab-treated patients, and it was confirmed that nearly 30% of patients improve. And as you have heard already, what is SDMT? This is the cognitive test where you have a small picture and you have to write down what number is connected with that picture. This is improving, so cognition is improving in patients treated with natalizumab. Again, something we didn't expect at all. Of course, these therapies have its burden. Higher effectiveness is always connected with more side effects, and the physicians using these potent drugs have to be well educated how to prevent them or how to treat them. Some patients have to be monitored very, very closely for blood count and autoimmune diseases and so on. And of course, it has impact on pregnancy planning. So unfortunately, our patients are mostly young ladies, so we always have to discuss this topic. So as I said, new guidelines will be issued next year, saying that you have to diagnose early, you have to treat early, you have to monitor properly the patients so you see activity not only clinically but also on MRI, and to switch treatment to more effective drug if you see activity. You have also, of course, discussed with the patient the risk-benefit, because not all patients are able to accept risk, but sometimes patients are more able to accept risk than physicians. Then, of course, pregnancy planning is an issue which will be handled in these guidelines. And for the first time, there will be a paragraph on primary progressive MS. which was without any hope until last year when ocrelizumab trial results were announced, showing that this will be a treatment for primary progressive disease. Though not big results, there was nothing up to now, so we are very happy that these patients, 10 to 15% of MS patients, will have some drugs. And siponimod is on horizon. It's another drug for secondary progressive MS. But I would vote for treating right from the beginning, not waiting until progressive phase occurs. And then what was promoted last year as well was something I used to appeal to patients, that they have to change their lifestyle, because these risk factors which led to MS are still there during their MS, and they have impact on how the MS develops. So if the patient is lazy, doesn't want to exercise, wants just to eat, smoke and watch TV instead of some cognitive training, the disease definitely will develop differently and worse. And so a panel of experts put together a report which has more than 80 pages of medical terminology, showing what is MS, why to diagnose it early, what to do with it, but also a handbook for patients, how to change their lifestyle. And you can find it on these internet pages. The brochure looks like this. Why time matters in multiple sclerosis. You have to start immediately. And changes in lifestyle cover these topics or these areas: physical activity, weight, active mind, smoking, alcohol drinking, and taking the medication, being adherent to medical treatment, drugs, and not only drugs for MS, but also for comorbidities like, for example, hypertension or something like that, because it also may cause shortening of life of MS patient if it is not treated properly. Of course, there are also unmet needs still. I'm very enthusiastic and I'm a visionary, but I'm aware of some limitations. We do not have predictive markers of prognosis and treatment responsiveness. So we cannot tell you when we diagnose an MS patient, we cannot tell the patient, your MS will behave that and that way, and therefore we will use this drug because your blood shows that this drug will be the right drug for you. We cannot. A lot of money was invested into genetic research showing which drug could be the right drug for the patient. None results yet. So the personalized medicine now is based on the contact with the patient, counting relapses, disability measurements, and MRI. MRI is the only biomarker we can really use and be sure that we see something. There is correlation, as I said, between atrophy development and disability development, and we can use it for prediction. Unfortunately, neuroprotection, we have no drugs for neuroprotection. The only way how to neuroprotection is made today is to stop inflammation right in the beginning. And of course, another unmet need is good symptomatic treatment for those where no other option is any more effective, so they do not respond to any disease-modifying drugs anymore because they are, well, in their EDSS 7, 8, and we know that the anti-inflammatory drugs are not working there. It's not that we do not want to invest money in them, but it's known that it's not working. So just to conclude, I'm happy that MS is treatable today for most patients, but there are some ifs. If we diagnose early, if we treat early, if we recognize early treatment failure, and you have to help your physician to recognize it. You have to keep a diary and see what's happening, what is your ability to walk, to do things of daily living. If patients are adherent to treatment, because no treatment works if you are not taking it, and if patients cooperate and change their lifestyle. The lifestyle changes are crucial, and they can really change the quality of life of MS patients. And with this, I would like to conclude and thanks my team. some questions?
I was diagnosed 10 years ago, and 10 years previously, I was diagnosed with fibromyalgia. I've never been on any MS medication. The only thing that's been put on is very low dose antidepressants. Now, having listened to you, I'm worried, but it should be on.
It depends on the activity of the disease. The question is, I was diagnosed 10 years ago, but I have problems maybe 20 years, and I was put only on antidepressant medication. In fact, antidepressant medication is not bad because it has some impact on the disease itself. We know that depressed patients have worse course of the disease because depression leads to some pro-inflammatory state. It's very complicated. I have no time to explain it, but it works in the brain on the cellular level. And if there were no attacks, then it's difficult to start treatment. Have you had any attacks?
I would have, I mean, over the years, I now have tremors. I'm tired a lot. Now, I had to give up work in 2002, and having given up work, it's made my life a lot better. But I'm kind of worried lately because my cognitive processing has gotten really bad recently, and my tremors have gotten worse recently. And I'm kind of concerned that I should be really maybe on some different medication or something.
Yeah, if there were no clear attacks, it's very difficult to start medication, or it was difficult in the years before. Now, since 2005 in European Union, it is possible to start treatment right when you are diagnosed. So you were diagnosed maybe in those times, but there was not wide knowledge about it. And maybe the reimbursement criteria differ in various countries. In Czech Republic, it has been possible since 2009, so we are always a little bit delayed. So I would also be a little bit concerned. You can do the physical training, you can do the cognitive training, and maybe with antidepressants you are able to keep your course quite stable. But on the other hand, if you have been treated right from the beginning, maybe your fatigue would be less, your cognition would be better. I cannot say. You know, it's always if we did something. But
I mean, I've never been as bad. When I was diagnosed with fibromyalgia, I was really sick. I was in hospital for 3.5 weeks.
Have you been on corticosteroids?
No. I have something called bronchiectasis as well in my chest. So I've been on steroids for that, but I find that my nervous system is very sensitive to any stimulus. So I kind of had to come off the steroids because I was kind of just, I couldn't sit down.
Yes, so intolerance of steroids, of course, is not good for MS patients because steroids can help a lot.
Yeah.
So it could be difficult. Maybe you would not respond to any of these drugs I was speaking about because maybe you wouldn't tolerate them. So.
Well, I should see my neurologist probably.
Yes, and to discuss it.
Yeah. Thank you.
Yes?
You mentioned the first injections to improve my son's got MS and he's in Edinburgh, and he used to inject with one of the
auto-injectors.
Yeah, one of them, which was leaving his life a half-life because of the side effects. So he consulted with his consultant, and he was diagnosed in 22 and he's now 33. Last year he's come off all medication, and he did have the sense to change his lifestyle more or less as soon as within a year of him being diagnosed. So he manages the condition now through activity, lifestyle change, diet, exercise, mindfulness, but he would have liked to have been eligible for cannabis resin, for the medically approved cannabis oil. But because legally his consultant couldn't promote, because he would have to take XYZ drugs for a period of time, and he was trying it, but they made him so ill. So now he's just, so to your knowledge, my question is there anything afoot to bring in inclusion of the cannabis, the medically approved cannabis oil? I know it's coming in California on approved, if they've managed to squeeze that in, and a number of other states are lining up to introduce it. Are you aware of that being pushed by the medical profession, included and part of the treatment part? Not saying the whole treatment, but to alleviate symptoms and to help the life of the patient.
The question was if cannabis could make a huge difference for patients who are not on disease-modifying drugs. I must warn a little bit. Cannabis is effective to alleviate some symptoms like ataxia, pain, and spasticity. On the other hand, it has bad influence on the cognition. So it should be reserved only for patients who are bedridden or wheelchair-ridden, who really cannot do anything, do you know. I would be not willing to give it to a 33-year person who is able to do his daily activities. So in his case, if he was really tired from injections, because really side effects of interferons may make your life very difficult, there is teriflunomide today, which has the same effectiveness without any side effects which you describe. So teriflunomide, which is Aubagio, may make it. So definitely I would vote for teriflunomide instead of cannabis in this stage of the disease.
Yeah. Has there been any studies done to show the effect of coming off fingolimod when pregnant?
Of what?
A year period?
Of what?
Of fingolimod particularly, just any impact of coming off the drug temporarily?
Normally, pregnancy is a state when immune system has to tolerate the antigens from the father. So the immune system is suddenly in the state which we would love to have for the whole life of a woman with MS. Unfortunately, it cannot be done. So it doesn't matter that the woman is not taking the drug. But then, of course, the period after the delivery for 6 months is a period of increased number of relapses. And there is not clear if breastfeeding, full breastfeeding can be a protection. We haven't seen it. It seems that the activity of the disease returns to what it was before pregnancy. So if there was high activity of the disease, we recommend patients to come back to the drug as early as possible, so breastfeeding for 2 months, which is necessary for forming of antibodies in the child, and then the child is protected by their own antibodies, and not to breastfeed or be off drugs too long.
So do you think, because I was suggested to go back immediately, do you think 2 months is safe?
2 months is quite safe. If you had high disease activity, it's better to do MRI. If there is activity on MRI, I would immediately return to the drugs. Because, you know, in Europe and in the United States, Canada, and this developed world, the child survives without mother's milk. Of course, it's not the case in Africa, but you are living in the developed country. And the healthy mother is much more important, you know, for the baby. Yeah.
I have MS, my 2 sisters have MS, and 4th cousin have MS. Generally said it's not hereditary. That is relatively changed.
Do you know, we have also families where 4 persons are diseased. There is a lot of research in genetics maybe you are carrying more susceptibility genes as the family. And the susceptibility genes are not genes for MS, these are genes for autoimmune diseases. We have, for example, 3 generations, and in each generation there is a different type of autoimmunity. But the autoimmunity is somehow made by these susceptible genes. So maybe in some families there are 20 susceptibility genes, and in some families there are 3. So this is my only explanation, but I'm not a geneticist. But definitely for your children and all the children of your sisters, I would feed the children with D vitamin. Yeah?
Can I just ask, for non-relapses, how often should a person have an MRI scan to see the progression of the disease?
If the patient doesn't have
Not having a relapses, the disease progression can still be seen on the MRI, but how often should an MRI scan be carried out?
in the guidelines, the question was how often should the MRI be done, because we sometimes see progression on MRI and no relapses. It is recommended to be done each year regularly if the patient is in the stage when the patient is treated. And when the treatment is switched, then it should be re-baselined to be able to compare it again. So at least 3 to 6 months after the switch to another treatment, there should be another scan. This will be in the guidelines. And of course, the health authorities and the reimbursement of MRI examinations will decide what will be realistic in Europe. But hopefully this is a realistic goal. Yes?
My sister was listening to Kerley, and she went on a drug and she was on it, and recently that she had issues with her headaches and mentally, insulin too as well. Do you think the smart move to move to a different drug, or do you think she should go back in and get another MRI kind of fix it, or she should just wait and let it go and see if cycles kind of go away?
The question is, the sister was diagnosed, how long it is? So it's this year. And immediately she went on Gilenya.
Yeah.
And she has headaches or what?
Basically, I've noticed that she didn't herself, she had headaches and blurriness.
Yeah. If it is now for more than 9 months, then of course MRI scan could be done, but maybe she needs some symptomatic treatment, and maybe she is not yet coping with the disease properly, do you know, so it may be a symptom of depression or something like that, which she may be ashamed of, and she's not speaking about it, so maybe also the consultancy of psychotherapist would be useful. But definitely MRI scan, soon MRI scan can solve if she is stable, and it is worth of staying on the drug, because normally Gilenya is very well tolerated and very effective. So if it is given right from the beginning, I would be happy to be able to do it for my patients. Yeah. You mean, is there any conjunction of MS and cancer?
Well, say 2 people in your family, say an astronaut died from neuron, the mother died from cancer, and the sister was there. Do you think that there's a correlation between
No. Because normally the immune system functions differently in cancer and in MS. In autoimmune diseases, the immune system is recognizing molecules which are of the own body, and it fights against them. So it is overactive. If you have cancer, it means that the immune system failed in recognizing these cancer cells and killing them. Normally it happens in all the bodies, that some cells go wrong. and the immune system is able to find them and kill them, and you do not notice. So it's a completely different type of error. So it shouldn't have anything to do with each other. Any other question? Yep.
Sorry, can I just ask one more question? Is there any link between infertility and
No.
No.
Not at all.
Because I suffer from infertility as well, and I have a child, which is great, but I don't have any born yet. And one of the problems that I was told was because my immune system was attacking like the sperm, do you know what I mean? So that's why I'm just wondering. I often thought afterwards.
The IVF itself may be a problem in multiple sclerosis. It depends on which hormones are used, because some of them may be pro-inflammatory and we can see attacks. If the obstetrician is not aware of this, is not trained in MS, then of course it may push the autoimmunity or the attacks. But infertility itself has nothing to do with MS. But, yeah? No. For example, teriflunomide doesn't have PML. Alemtuzumab in multiple sclerosis has not yet any PML. And ocrelizumab in MS also doesn't have PML. Some of these drugs were used previously in oncology, where you use a lot of drugs which may cause PML. So of course PML also occurred in patients treated with alemtuzumab or rituximab. But this is not a causal effect. You know, they were pre-treated with very many cytostatics, and also some types of cancer lead to PML even without any treatment. So there is a lot of drugs which are not connected with PML. Yeah, Copaxone is not connected with PML at all. And we haven't seen anybody who had PML twice. Yeah, the Tysabri leads to PML. It is the drug which is the most cases of PML are connected with Tysabri, of course. It's around 600 all over the world now. One more question, she said.
Just on the subject of...
There was a lady. I will stay here for some time. There was a lady up. Yeah. It's like, the effectiveness is like interferon. The side effects may be different, so if the patient doesn't tolerate interferon, it's wise to switch to Copaxone, but not because of efficacy reason. It's the same line. The head-to-head studies showed that it's completely the same effectiveness.
With less drugs, what's the NNT for the number of people to treat? Do you have anything for that?
We have for all these drugs, there were counted NNTs. I hate this way of using this. It's for regulators. It's not for clinical practice. It is not useful when the patient is sitting in my office. NNT means number needed to treat to avoid some activity like relapse or disability progression, for those who do not know what is NNT. You never can base your clinical practice on using these numbers. So you can find all of them in literature, but regulators who have never seen a patient with multiple sclerosis are relying on these numbers, not us clinicians.
So you don't wish to discuss NNTs, is that what you're saying?
Not now. I don't think it's a topic for this audience. And personally, I'm not fond of it, even as a clinician.
Thank you very much.
Eva, thank you so much for such a, I think it was a very clear, informative presentation, but the thing that jumped out most at me was your passion. I mean, a very, very clear, passionate lady, and I think for me it would be to continue with that passion, and that vision you talked about is so important, and that dreaming big I think is incredibly important. But I think again what was really, really clear was the lifestyle factors that Eva mentioned, and how important that is, how much you can take control of that in one's own life, and also the importance of treating early, and how we really need to look at that, especially I think here in Ireland. And one of the things that jumped to mind here was one of these statistics actually, was around the how long it takes between the first diagnosis, and it won't jump to mind to me here now. How many months is it? 12 months, yeah, how long it takes between somebody actually receiving a diagnosis and receiving treatment. And I mean, based on what you're saying, I mean, we really need to look at that. And I should say to everybody that MS Ireland is looking at the whole area of healthy brain, and that is something that we are going to work on in 2017. But again, thank you so much for a wonderful presentation. I'd now like to introduce you to our third and final speaker for the evening, Conor Kerley. Conor received his bachelor's degree in human nutrition and dietetics from Trinity College Dublin in 2010. He commenced nutritional research studies at Connolly Hospital and the National Children's Hospital with the School of Medicine at UCD, and recently completed his PhD. He currently works with the MEDEX programme in the School of Health and Human Performance in DCU, and with the Heartbeat Trust, a multidisciplinary heart failure treatment and prevention foundation. In addition, Conor is chairperson of the Scientific and Research Steering Group of the Irish Nutrition Dietetics Institute, and his areas of expertise include heart and lung disease, as well as vitamin D and autoimmune disease. If I could welcome him to the stage.
Good evening, everyone. Thanks for that, Eva, and thanks for the invitation to MS Ireland and Novartis. So I'm going to speak mostly about nutrition. So if anybody's tweeting live or anything, we have this is my Twitter and my Facebook if anyone's interested in that. But as Eva showed already, we have a huge disparity in multiple sclerosis rates around the whole world. And really the question is why? Is it because of genetics, or is it because of environment? But really, some of the best studies we have are that genetics account for about 25% of risk, whereas the environmental factors seem to account for more, be a little bit more important. And really, if you only remember one thing from this evening, or at least from my talk, really remember genes are not your fate. This is really, really important. So we've all heard a lot about sunlight and vitamin D, but it turns out that sunlight may have additional benefits compared to vitamin D alone. And just some general rules of thumb. So about 5 or 10 minutes of sun is enough, a couple of times per week. In general, you want to expose more skin for less time, as opposed to less skin for more time. Okay? You never ever want to burn. This is a really important topic. And of course, certain foods which are rich in antioxidants protect the skin from within, for example, berries. So another rule, and I've just called it here Kerley's rule, is your shadow must be shorter in your body for vitamin D production. So it's a very easy rule of thumb. It doesn't matter where in the world you are, what time of day it is, or how much clothes you are or aren't wearing. If your shadow is really, really long, you're not going to be making any vitamin D. So as I always say, romantic walks on the beach are fine, but they're not going to cut it for vitamin D. Okay, so no vitamin D production. Okay, and of course, if you already have MS, vitamin D deficiency is associated with more severe MS. It does seem like a good idea. But if we talk about vitamin D sources, so I'm a dietitian, we can get all nutrients from food, right? Not really, not when it comes to vitamin D. So we have over here, we have Swiss cheese, liver, egg, cereals, fortified milks, then you come into some of the oily fish, and this is the recommended daily allowance. And this is a typical supplement of 2,000 units, so you can see really, you're going to have to eat quite a lot of fish and about maybe 100 eggs, well, maybe not 100, but quite a lot of eggs to get enough, okay? But if we put that into context, what about sunlight? So now we see the same graph, so you've got, sorry, I can't figure this pointer out. We've got all the same sources. This is the recommended daily allowance, this is the supplement, and this is sunshine. How much sunshine? 20 minutes will get you this amount. If you've got Caucasian skin, 20 minutes if you're in a swimming suit, okay? And remember Kerley's rule, short shadow, okay? So all vitamins from diet, as I say, I'm a dietitian, with one exception, and that's vitamin D, unless, of course, you eat a lot of fish. But it does have to be a lot of fish, okay? It's not going to be enough to eat a small portion of fish here and there. Okay, but I really want to talk about dietary patterns in MS. So this was a study, a nice study done in 20 different countries, published in the 70s, late 70s, and we still don't really hear a lot about things like this. So MS severity, so how severe someone's MS was associated with all these products. So meat, eggs, butter, full of saturated fat, sugar, empty calories, milk again, a lot of saturated fat in there, and then total fat intake as well. So very interesting. If we fast forward about 20 years, this is a big, large study done in the US. Again, we see the same thing. So high meat consumption, a diet low in fish, where we get omega-3s, and high in dairy products, again, associated with MS. So if we look on to the next year, this is one of the largest studies ever done, 36 countries. And again, we see our saturated fat, animal fats were linked with MS severity, so how severe someone's MS is. Again, another study this time from Canada. Again, you can see the factors: animal fat, excess calories. So in other words, eating more calories than you need. And again, vegetable protein, obviously we can only find that in plant sources, so beans, grains, nuts, seeds. Fiber again, as I always say, the rule of fiber is you're only going to find fiber in plant products, and it's whole plant products. You're not going to find any in sugar or refined flour or things like croissants, but you'll find lots in fruits and vegetables, beans, grains, nuts, things like this. Vitamin C again, mostly from fresh fruits and vegetables, and potassium again, mostly from your fruit, veg, some in dairy and some in whole grains as well. So this was a nice study done a couple of years back in Croatia, again associated with a diet rich in meat and fat. You can see how consistent some of the studies are really showing. This is a really interesting study. What they did was, unfortunately, these people with MS had died of whatever reason. This is back in the 60s. So they looked at the analysis of the brains. They saw that the people with MS had more saturated fats in their brain cells. So anyone ever heard of you are what you eat? Maybe it is true. Same thing shown, more saturated fat in the blood cells, so higher saturated fat and lower omega-3s in the blood cells of people with MS compared to those who didn't have MS. And again, this one's shown higher saturated fat was associated with worse outcomes. So the more saturated fat, the more disabled you're likely to become. So we have to look at some intervention studies, and this means where we get people to change their diet, and what effect does that have. Okay, so this is a really nice study, the ARM study done in the UK, and they recruited 83 people and asked every single person to do the same thing: decrease saturated fat, increase polyunsaturated fat, which we get in things like nuts and seeds, and increase antioxidants again from fruits and vegetables. And they studied them over 3 years, and what they found was those who complied with the recommendations did not get any worse within the 3-year period, but those who got the advice but didn't stick to the advice got worse, significantly worse, over that 3-year period. And again, this is in 87 when there wasn't a huge amount of MS drugs available. So most people will have heard of Roy Swank. I'm going to talk a little bit about his studies. So he really was looking at a protocol looking at 15 grams of saturated fat per day. Okay? Anybody know what that looks like, 15 grams a day? So you're talking 3 or 4 pats of butter. So you know you get the little pats of butter in the hotels and stuff? Most people, especially in Ireland, tend to use a lot more butter than just one, for one slice of bread or whatever it is. Half a small pork chop. Okay? Anybody take half a chop? No, most people would have at least 1 or maybe 2. And that's just one meal. Again, cheese, about 2.5 matchboxes. Think of the little size of a matchbox, 2.5 of those. Or a pint of milk. Now, most people in Ireland have some milk throughout the day, have some cheese, have some butter, have some fatty meats, and all of a sudden you're up at 60 grams of saturated fat. So way exceeding this 15-gram limit. Okay? So this just shows, you know, what Swank was talking about. But his study, some of you might be aware of some of the intricate details. So 144 patients. He started this study in 1954. I certainly wasn't born then. So he split people into 2 groups. Again, he asked everyone to follow the same diet, those who stuck with the diet and those who didn't. And he published the results over and over again in some of the best medical journals, New England Journal of Medicine, The Lancet, and others as well. And these are some of his results after 34 years. Now, I'm a researcher. I do some research. Some of my research lasts hours, some of it lasts weeks, and some of it lasts months. 34 years is a huge undertaking, and even some of the data that Eva presented shows maybe results after 5 or 10 years, but 34 years is a huge undertaking. Sorry, that slide should not be there. So this is the percentage of people who are physically active after 34 years. 97% of those who stuck with the diet were still active after 34 years, whereas with those who didn't comply with the diet, only 7%. Okay? And again, this is the death rate, and again, 0% in those who stuck with the diet compared to those who didn't stick with the diet, 63%. Okay? So he actually published a 50-year follow-up, so 50 years. We have to remember that most people in this study were maybe in their 20s, 30s, and 40s. So someone in their 40s is now in their 90s when he's following them up. And you can see that 13 of the 15 that he was able to track down were still active. We're still active. And you can see that some of them had really nice skin. So maybe the diet's good for the skin as well. Okay? So Swank says, consistent with what Eva said, that the results are best with those who start with minimum disability. So again, really, really important to target MS as soon as possible. But crucially, regardless of level of disability, those with good compliance did not deteriorate significantly. So even if someone hasn't had a good diet or lifestyle up till now, it's never too late to change. We can control some of the future, perhaps. Swank wrote that high sensitivity to fat suggests that animal fats are directly involved in the genesis of multiple sclerosis, and genesis meaning the beginning. Okay? So Swank seems to be remarkable. He recorded the first ever study of diet in MS, and everybody thought he was crazy at the time. He lost a lot of friends and a lot of colleagues because of this. His study lasted 50 years. That's unbelievable. I could not imagine designing a study now to last for 50 years, published when I'm turning 80. Okay? Swank lived to be 99. So whatever he's doing is probably a good idea. He worked as a scientist till he was 94. Again, I hope I'm not working when I'm 94. So this is a US radiologist, and he wrote in 2012 that Swank's results remain the most effective treatment for MS ever reported. So we don't really hear about this. And of course, Swank's results do have some criticisms, which are really important, but it's just important to note that even so, really, really effective. And again, some of you will know about George Janelek's results from Australia, the Overcoming MS group. Major hope. So what he did was he recruited people 5 days, he brought them into a home and they stayed there for 5 days, and it was specifically for people with MS. And they promoted lifestyle changes. So he studied 165 people, and they just completed questionnaires after 1 year, at the start, after 1 year, and after 5 years. And again, what you can see is, after 1 year, people got better in terms of their overall quality of life, mental health, and physical health. And you can see this kept getting better over 5 years. So again, really, really good evidence. And some of these people were on medication, some weren't. Some were newly diagnosed, and some had MS for a long time. So some nice evidence from Australia. And Prof. Jelinek himself said some people didn't get better, and some people didn't stick to the recommendations at all. But on the other hand, some people got dramatically better, so they had complete resolution of symptoms and are completely well. So again, this is major, major hope. And what are the lifestyle modifications? Some of you will have heard of this. So a plant-based diet full of, again, we said whole grains, nuts, beans, grains, legumes, fruits and vegetables, omega-3 fats, sunshine and vitamin D, meditation, exercise and medication. But not everybody was on medication. So can nutrition work? Yes, and how? Through antioxidants, increased brain blood flow, the microbiome, immune system, and decreasing inflammation as well. So quick recap of the evidence. Do not smoke. Smoking is related to higher risk of MS, and it's also related to higher risk of your MS getting worse quicker. Okay, so really good evidence. So no puffing, please. Keep your immune system balanced to reduce infection risk by following these factors: eating well, sleeping well, physically active, not smoking, and vitamin D levels. Try to avoid stress. Make sure you get enough vitamin D in your blood. This is something really simple that we can all do. And where can we get vitamin D from? Oily fish is really the only worthwhile dietary source. Again, vitamin D supplements and sun. Unfortunately, we're not going to get any sun in Ireland for another couple of months. Look for vitamin D3 as opposed to vitamin D2. And how do you know you're getting enough? Your doctor can test you, and the test is called 25-hydroxyvitamin D, and aim for a blood level at least above 80 nanomoles per litre. Be physically active. So if anyone can't read, the cartoon says, what fits your busy schedule better? Exercising for 1 hour a day or being dead 24 hours a day? And really, exercise is that important, and that's been shown across multiple diseases, and including in those without disease. And it's been shown in Ireland by Susan Coote from the University of Limerick, which is partially funded by MS Ireland as well. When it comes to nutrition, decrease your saturated fat, particularly overall fat and particularly saturated fat. Try to increase omega-3 from green veggies, flaxseed, walnuts, and oily fish. Increase your fruit and veg. Try to replace fatty meats with beans, nuts, and little oily fish like salmon, sardines. Avoid high-fat dairy and try to achieve a healthy weight. Before you make any changes, speak to a healthcare professional. Really important, so if you cut something out, that you're not missing out on anything. And I just want to finish off this evening with a case study. So we have a 15-year-old boy, year 2002, admitted to A&E with almost total left-sided paralysis. So you'll be familiar with all these scans: CT scan, MRI scan, lumbar puncture, and treated with steroids. 3 months later, we got facial paralysis and treated with anti-epileptic medication. Another couple of months later, we have another MRI with another relapse and treated with steroids again. So 3 relapses, 8 months, plus the clinical findings, diagnosis of relapse and remitting multiple sclerosis. So shortly after diagnosis, interferon therapy was started, which is one of the injectables, but discontinued after 4 months because of discomfort. However, upon discontinuation, comprehensive lifestyle changes were made. So that was in 2003. 13 years later, this boy is still medication-free, still relapse-free, and still symptoms-free, and that is, of course, me. So I'd like to finish by inviting any questions from the floor, and I'll leave you with my slide with some of my interpretation of the evidence. So thank you. Do we have any questions? Yeah?
So are you suggesting being vegetarian, this person with MS?
I think certainly the best evidence we have is that a plant-based diet is really is a smart choice, and that's really for most people, and that's consistent with some of the best evidence we have in cardiovascular disease and cancer as well. So it doesn't necessarily have to be fully vegetarian, but certainly plant-based and whole plants. We can be a vegetarian, live off crisps and donuts and.
So is the animal fats kind of where you're considering fat included with fish, and fats being fish as well? Are you talking about putting in fishes?
Well, some of the best evidence we have is that oily fish is good, but oily fish still contains quite a lot of saturated fat. So the jury, in my opinion, is still out a little bit, but oily fish would certainly be a lot better than a steak, for example. Okay? Yeah.
I did a conventional nutritionist. I did not a detox, clinical exclusion diet.
Yeah.
I knew I was already intolerant to wheat because I get really bad reflux.
Yeah.
But after doing the exclusion thing, I also discovered that I was intolerant to dairy. Like, I looked about 5 months pregnant every night. As soon as I ate the dairy, then I went. But I'm kind of nervous because of all like calcium and stuff like that. So, like, what should I be doing to replace? Like, I've taken dairy out of my diet almost completely.
Yeah. So the question is, if someone follows an exclusion diet and eliminates wheat and dairy, that what they need to consider. So I can't really provide individual advice to anybody. I don't know your own history and your own habits and so on. But I mean, there's lots of different sources of calcium in the diet. It doesn't have to be dairy. And also things like vitamin D are going to be important. And there's lots of other things apart from calcium which are important for our bones. So there's a lot of different ways. So for example, like sesame seeds, chickpeas, certain fruits and vegetables will have a lot of calcium in there as well. Okay? So, so the question is a gluten-free diet advisable? And really, we don't have any good evidence for that at the moment. There is some interesting papers, but we don't have enough evidence at the minute to say that it is beneficial. On the other hand, we can say that it's probably not going to be too harmful. But if someone enjoys gluten, I certainly enjoy gluten from time to time, and I don't think it's a major problem for most people. But if someone feels they would rather not eat gluten for whatever reason, that's a different thing. But we don't have the evidence at the moment. Okay, I think just the next row, yeah. Yeah, so the question is about tin fish, are they as good for us as fresh? And again, it depends on the context. In general, the best dietetic advice we have is to try and go for as fresh and as whole as possible. So tin would be a little bit processed, but in general, the tin fish, like as you say, sardines and mackerel and so on, they can be very good choices, and they can be quite cheap and quite convenient. They will still contain vitamin D, but just be careful. In Ireland, we eat a lot of tin tuna, and there will be no vitamin D in the tin tuna. So things like sardines and mackerel will have the vitamin D. Okay, I think this will. Yeah.
So you're saying to everybody that it should change over to this diet without any question, like almost plant-based with some dish?
No, I'm presenting the evidence. So I don't know anybody's own circumstances and own medical conditions and history and so on. So I'm not providing anybody with advice. I'm providing the best evidence that we have at the moment.
So that's the evidence you're saying is plant-based diet?
Well, I haven't gone through it all, but that's a quick 15-minute synopsis of a quick snapshot. Yeah.
Is there any downside apart from electric gas?
So, I mean, if someone switches over, if someone eliminates anything from the diet, they need to be careful that they don't miss out on anything important. But, I mean, there's no reason why a plant-based diet will provide everything that we need as well. I'm just behind. Yeah, the lady at the back. Yeah, you. So there are some studies showing that sugar is correlated with a worse outcome, but we don't have as much evidence as we would for animal fats just yet. But I mean, we would probably expect that it would have as bad effect, but we don't have that evidence. It's not that strong. Sorry. So the question is about watching your blood sugar levels in general. And I think that's. I don't think there's a need for anybody who's not diabetic to be testing their blood sugars, but I do think it's important that we all, our blood sugar levels should never be up and down all day, every day anyway, and that goes for if we've MS or not. Yes?
For a person's sanity, if they like the odd steak, or they like the odd whatever, is it okay to have a slow day? Because of the shifted benefit emotionally to doing something.
Yeah. So I think really it comes down to the individual circumstances, and I'm going to reference a guy from America called Dean Ornish, and he speaks about a spectrum. And basically, if someone has really severe disease or whatever it is, whether it be cancer or diabetes or heart disease or MS, that really the best evidence we have in all of those diseases is to be as strict as possible with medications, with exercise, with diet. But if someone is quite healthy and is looking to stop progression of either getting a disease or that disease getting worse, that they have a lot more leeway. But at the same time, as you say, it's about weighing it up. I know a lot of people who follow the Overcoming MS program, and can be quite miserable because they're quite restricted, and I think that's wrong as well. Yeah, I usually say that. Yeah, maybe we can write off it. So the question is, maybe we can write off. We can ask the government for 3 holidays a year. Yeah, so maybe we can write it off as a medical expense. Yeah. Yeah. So maybe we need to set up a support group or something. Yeah.
Yeah, I she told me to go back on a week to get her results. And then a few weeks, the symptoms subsided a lot.
Yeah.
And then I ran into the coach together.
Yeah.
And I've been trying to follow this making it take a lot of symptoms. But what's been happening when you're finding obviously it's like a section of alternatives. And what I'm finding is a lot of the alternatives are quite sugar-based then as well. You know, so it's kind of like that MS thing on Saturday as well, and the nutritionist speaking and everything she's suggesting, he said for her, well, that's just what sugar. And we're like, well, you know, you have MS, don't worry about diabetes. You know, it's kind of
So the question is basically that if we start cutting out a lot of these foods, that a lot of the replacements have a lot of sugar or maybe other additives. So yeah, you're completely right, and it is very tricky. What I will say to kind of a vulnerable and curious audience maybe, to be careful who you get your nutritional advice from. particularly online in a magazine or anything like this, or down the gym or down the pub even. That really the only people in Ireland that's just come out really in the last week or two that are qualified to give nutritional advice are dietitians. So not a nutritionist, a dietitian. And that's particularly important when it comes to a medical condition, because with a medical condition, it's complicated by a lot of different factors and of course medications as well. So just to be careful where you get your information from. Now if we talk about specific alternatives, what I would say first of all is that if you're looking to cut out maybe meat, that instead of maybe always looking to replace it with a fake meat or something that mimics the meat, that just look for other alternatives in your diet. So instead of having a spaghetti bolognese with mince in there, you might have a spaghetti bolognese with extra vegetables and maybe some lentils, and you leave out the mince altogether. And some of these alternatives certainly can be really high in sugar and salt and maybe even fats as well. So it is really important to keep that in mind. Falafel? Yeah, falafel can be a good alternative as well. I think, have we got time for one more? One last final question. So this lady waiting patiently. Your children. So again, I can't really advise anybody, and unfortunately when it comes to vitamin D, I've done several vitamin D studies and the response is so varied, and really we can say this for nearly any intervention, that the response is really very varied. I've just finished last year a study actually looking at children with autism, and we give them 2,000 units per day, and some children's levels shot up and some increased slightly, but some children decreased. So isn't that amazing? We give them 2,000 units and we're pretty confident they took it. We assessed how much they took, and at some people's levels, some children's levels decreased. So that's the importance of assessing, taking a blood sample. So with a child, I would recommend, liaising with your GP or with your consultant and then titrating the dose. So you have a look at maybe after 2 or 3 months on that dose, is it enough? And me personally, I take vitamin D in the winter, but not in the summer. I try to get my sunlight. So, and the same will go for kids, and I say 5 or 10 minutes is more than enough. And just one last comment before Eva comes up. There is some recent evidence from Bruce Hollis and his group in North Carolina showing that the response to vitamin D supplements is blunted in people with MS. In other words, someone with MS does not increase their vitamin D level the same as someone without MS. So again, this is the reason why testing is important. But I would recommend you start your supplements for maybe a couple of months and then you test, as opposed to testing before your supplements. Okay? So thank you very much again, everybody.
Conor, thank you very much again. Very clear, very informative, very practical, slightly challenging, I suppose, to all of us. But thank you again, Conor, for your presentation. All that's left for me to say is to thank our 3 speakers, Nonnie, Eva and Conor, again for really, really engaging presentations. Also, huge thanks to Novartis for supporting this evening. It was all available to people and will be available on MS Ireland's website. So to thank each and every person here in the room for physically attending, and thank anyone who's online as well for joining us this evening. So on behalf of MS Ireland, thank you very much for coming. The MS Ireland services are always available to people. Again, I would say to go on the website, there are local services available to you, whether it's individual one-on-one with the community worker or whether it's some of our respite services. That's all available to anybody with MS. So thank you again for coming. Safe home and Gurmil Magot Sonawaya.